Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we are joined by Dr. Brandon Baraty and Associate Professor Viraj Kariyawasam, two leading experts in gastroenterology, to discuss the latest in inflammatory bowel disease or IBD management and bowel cancer screening. They'll share insights into the most recent advancements in diagnostic techniques and cutting-edge treatment options shaping the future of patient care. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare, education and research. Dr. Baraty is a Senior Gastroenterologist, Hepatologist and Endoscopist. He is the Head of Discipline of Gastroenterology at Macquarie University Hospital and the Director of Endoscopy at Ryde Hospital. Dr. Baraty specialises in IBD care and is a leading expert in transabdominal ultrasound for IBD assessment in New South Wales. Associate Professor Kariyawasam is a Senior Gastroenterologist, Hepatologist and Endoscopist at Macquarie University Hospital and Concord Hospital. He holds a PhD from the University of Sydney and has completed international fellowship training in IBD. He is dedicated to advancing IBD diagnosis and management while actively supporting patient advocacy and education. Associate Professor Kariyawasam and Dr. Baraty say they are passionate about improving the lives of people with complex conditions like IBD, and they join me now.
Hello, Sally, and hello to our listeners. I'm sure Viraj will agree that though we're both very passionate about IBD, our work involves all aspects of gastroenterology and liver disease, and both of us seem to have a lot of experience with advanced therapeutic endoscopy, which is really helpful in both IBD and bowel cancer screening. But in all honesty, given the ratio of gastroenterologists to the growing population size in Australia, we really don't have any choice but to be experts in all areas of gastroenterology care.
Absolutely, Brandon. This is a growing field, and I think, in my opinion, gastroenterology is at its very infancy and growing. However, there is a huge lack of gastroenterologists around Australia, and there's a big demand. And as gastroenterologists, clinicians and researchers, we both are into improving the care given to these patients and work well with our other GP colleagues, specialists, in managing IBD and all the full spectrum of gastroenterological conditions.
The Australian Institute of Health and Welfare Statistics seem concerning, with increasing overall cancer rates and more people having cancer earlier in their 30s and 40s. Brandon, is it the same with colorectal cancers?
Firstly, as probably most of our listeners know, the cancer rates in Australia are overall increasing. In 2000, there was 88,000 new cancers with an age-adjusted incidence of 0.58%. In 2024, we were at 169,000 cancers with an age-adjusted rate of 0.62%. And we are attributing this to an increasing population size and an increasing age with our population. It's actually expected in 2034 that the number will have increased to 209,000. Thankfully, mortality from cancers is decreasing slightly, and in turn, cancer survival has increased from 55% to 71%. Unfortunately, though, the cancers still account for 3 out of 10 deaths. And you're right, Sally, the cancer rate in younger adults is increasing, and the top 2 reasons for the increased incidence is colorectal cancer and thyroid cancer. Most of our listeners are aware that since last July, the screening age for bowel cancer screening was decreased to 45, and I think you'll understand why in a second. Colorectal cancer is interesting. The rates have actually had the largest decrease in comparison to all the other cancers since the year 2000. Between year 2001 and 2024, the incidence rate dropped from 86 per 100,000 people to 57 out of 100,000 people, and the 5-year survival increased from 56% to 71%. But this is data for those older than 50 years old. When you look at those under 50 years old, the incidence rate actually increased during that same time. It went from 22 per 100,000 to 30 per 100,000, and luckily, these are the age group that cancer survival is the highest for. Colorectal cancer still remains the 4th most common cause of cancer.
So, Viraj, how do these trends translate to what you're seeing in clinical practice?
How do I see it in my practice, Sally? I think in the last 13 years, we all gastroenterologists have seen a significant increase in cancer and also precancerous polyps being identified in younger people. Especially, we were never seeing polyps or precancerous lesions in a 20-year-old or a 30-year-old long time ago. But now, this has become very common, and we are seeing more and more precancerous lesions being identified in patients who undergo colonoscopy for completely unrelated symptoms, where we would have never identified polyps in the past. So I think even though the data is showing that there's an increase, yes, there's a 20 to 30% or some, in essence, we are quoting a 300% increase in cancer rates in the younger population, especially when it comes to colorectal cancer. We may be underrepresenting it because there are a lot of precancerous lesions removed in patients, preventing them from getting cancer. The unfortunate thing is there's no robust guidelines in how to manage these people who have precancerous lesions identified under the age of 50. Therefore, these issues needs to be addressed fast so that we have ways to manage these patients who have cancers as well as precancerous lesions identified at a very young age.
Viraj, I couldn't agree more with you. I think things change from experience, if you agree. When I first finished my training, we used to stick to guidelines very closely. When people were under the age of 50 and they had minor symptoms and were low risk for cancer, we often would essentially turn them away from a colonoscopy. And now my practice, and I assume you and my colleagues as well, are a little bit more vigilant, even if the client is younger, that we will probably do the colonoscopy. Because you're right, I just scoped somebody that was 22 years old yesterday, and they had a pretty large tubulovillous adenoma in their rectum, which, if they waited till screening age, would definitely be a cancer.
So, Brandon, what are the different screening methods and how effective are they?
First of all, we need to remember that screening means testing those without any symptoms. As Viraj mentioned, symptoms often lead to endoscopic evaluation, also finding of precancerous or cancerous changes. But we're targeting the general population and generally people who don't have any symptoms. So as far as screening goes, in Australia, the formal national screening started around the time actually that I arrived from Canada to go to University of Sydney in 2006. And the newer and more specific immunochemical FOBT, or fecal occult blood testing, started in 2020. The cost-benefit models show that it was equivalent to screening with colonoscopies for those that were without symptoms based on age and at risk. It's still only has a 60 to 85% sensitivity rate when used regularly on the 2-yearly screening time allocation, and only 30 to 50% pickup rate if it's only used 1 year. Furthermore, they only account for about 14% of colonoscopy reasons per year. But unfortunately, there's also discrepancies in participation rates. So at best, we're getting just under 50% participation rates in metropolitan areas. And health literacy, cultural issues, and location-based reasons mean that there might be less participation. So if someone can't read the English letter that's been mailed to them saying, please do this test, they might not do it. Or if they don't understand the implications of doing the test, they might do it. For example, in the participation rate in New South Wales was about 42% recently, but in Northern Territory, it's only 27% of the population. And our First Nations populations generally don't participate as well as the rest of the population. We also do some screening if there's a family history, and our kind GPs kind of bring it to our attention.
So, Viraj, what issues do you come across and how do you think they can be addressed?
I mean, what we need to first of all realize is we are one of the lucky countries. We have a national bowel cancer screening program, and I think it's amazing. We need to always applaud what we have and appreciate what we have. A lot of the other countries doesn't have this. So I think the biggest issue that we have is the participation rate. As Brandon said, there's a huge variation, and in a free test with only 40% participating, that's unacceptable. And I think we as general practitioners, specialists, and educators have a huge role in to get this up to at least acceptable levels of 75%. So there's a long way to go with that. And the other issue that I see is that immunochemical testing or immunological fit testing is ideally need to be done every year. Where we're seeing is it's only done every 2 years in Australia. And if you miss the test and if it's not done regularly, the benefit of the test decreases. So we need to educate people about the frequency and the fact that it needs to be done regularly. And because we are seeing an increased cancer in the younger age, even though as gastroenterologists, we're being advocating that this test needs to be done from the age of 40. Unfortunately, because of monetary issues, it was only approved from 45. And I think we need to push that age needs to be reduced to 40 at least. And for patients who have symptoms, I agree with Brandon. There's no argument. They definitely need to be referred to a colonoscopy, and that needs to be the norm. The immigration and the health literacy is a big thing, and gaps are a big issue in our clinical practice. I work at Western Sydney. I work in Western Sydney, where there's a lot of immigrant population, and there are issues with ethnicities who don't want to do the stool test because they are concerned about it. And we all do our part. And I think as part of an organization called Pink Sari, I have been participating in a lot of seminars for the community to increase the awareness, especially the South Asian community, where they do not take part in the FOBT screening because of lack of awareness and cultural beliefs. So we all need to do our part in improving this uptake. At least that will help to reduce the rate of colorectal cancers more.
And how would a general practitioner explain the implications of an FOBT result to a patient who is anxious about the possibility of cancer?
Yeah, we see it all the time. And I think it's really important that we tell the patients what to expect and what this test means. And our general practitioners needs to understand how to explain that. Just to go through the data, like what Brandon said, when 100 people do a test, the rate of positivity sits around 6 to 7%. So it's only about 1 in 14 patients would have a positive test result. So it's very important to tell that, yes, you are a selected high-risk group. You've had a 6 to 7% of having a positive test. And after you get a positive test, the most important thing that we need to highlight is that majority of the time you're not going to have a cancer. The cancer rate is only about 4 to 8%. So patient understands the absolute risk of a cancer in them. And if they've had this test regularly over the period of time from the start of the age of 50 or 45 now, their risk is going to be low to have an advanced cancer. Most of the time they would have an early bowel cancer. And if they have an early bowel cancer, they have a high cure rate. So they have good outcome. So all these aspects needs to be explained to the patient. And about 50 to 60% of the time, the patient would have what we call a pre-malignant condition that would actually prevent them from getting a cancer. So it's important that we explain this information to the patient so they're not worried and they don't think, oh my God, I have a bowel cancer. Because it's not the case. It's a preventative test, and that's the whole purpose of it. And that can be utilized to encourage their family members, their friends, and everyone else to do the test. This is something we do in our practice all the time, Brandon. Isn't that so? So you would tell them, go and tell your friends who are not doing it. Please do it. You've stopped yourself from getting a bowel cancer.
Yeah, I tend to even ask the patients that come to me for other causes now on a general basis if they've been doing the FOBT test, and if not, I'm more likely to offer them a colonoscopy as screening if I think they're at risk, even if they're asymptomatic.
Brandon, if a referral is made based on symptoms, family history, or FIT test results, can you tell us what are the next steps?
Yeah, so generally, everything in medicine is going to be a case-by-case approach, and some of our clients may need further examination or investigations, but in general, an endoscopic evaluation is needed, especially as it still remains the only safe method of removing or treating early cancers before requirement of surgery or chemotherapy. Our equipment has improved, our training is in general more advanced, and there's increasingly evidence-based therapeutic measures. And we even use AI technology now to help adjunct our skills or pick up polyps. Our national guidelines are also evidence-based now, and any surveillance procedures are based on decades of national and international data, and it kind of balances the risks of our procedures with the benefit of doing it. in the end, the client's going to need a colonoscopy, not only to be able to visualize what's going on, but also to be able to hopefully treat what's going on.
And Viraj, can you tell us what happens in your practice?
It would be pretty similar to what Brandon described, Sally. Once a referral is made, if there is an urgent need, especially based on their categorization, you would either want to see the patient quickly or get a colonoscopy organized for further assessment, especially if it's a positive FOBT. And I've been very lucky enough to be part of the National Bowel Cancer Screening Guidelines, and also the bowel cancer, the colonoscopy categorization guidelines in New South Wales, where I was able to put my input so that we can improve access and have robust evidence to do these procedures in our practices. And because the lack of resources is a big deal, a big problem in doing colonoscopies. And one of the other issues that we have all faced is the poor bowel preparation, because bowel preparation not being adequate to identify polyps is a problem in our colonoscopies. And me and Brandon are part of a clinical trial that we have designed to provide support to patients through an AI-driven bowel preparation app that is helping our patients to achieve a better bowel preparation, thereby reducing the need for repeat colonoscopies by freeing up more resources for the people who need colonoscopies. And we are running this study at the moment at Macquarie University Hospital. And these are the ways that we would increase these access issues or resolve these access issues. And another thing is that we need to prioritize patients to get what we call open access or direct access colonoscopy, where people are lack of comorbidities, who have no other risk factors, who's got only a FOBT positive result. They should be directly coming into a colonoscopy, and we try to provide that to our patients through our practice.
So how did GPs arrange this?
Usually, if they do have a general practitioner, a gastroenterologist in their area who they do refer to, they should always have that discussion with that gastroenterologist. For instance, me and Brandon have that access within our websites. The GP can utilize that simple form and fill in all the patient's details. There are tick box things to check whether they are qualifying or not qualifying for a direct access colonoscopy. And if they qualify for a direct access colonoscopy, they can be directly referred and they will be contacted by our staff and booked in directly to have a colonoscopy, which will save time and money for the patient and get them the results they need quickly.
And Brandon, what is the process at Macquarie University Hospital?
So Macquarie is quite interesting in that you have some of the best doctors and best gastroenterologists from all over the city coming to one location to help our clients. We actually do a lot of direct endoscopies at Macquarie, and right now most GPs will refer to the individual gastroenterology practice, and then the gastroenterologist will then create the pathway to have the procedures done at Macquarie University Hospital. But we are actually working on creating a centralized referral system, which will make it a lot easier for our GP friends. And this will be on the Macquarie University Health website and will be available soon, so that it's a form, and thereafter, simply the patient can bypass being reviewed by a gastroenterologist if they are meeting the criteria and go straight to endoscopy. After the endoscopy, it allows for more of a rapid response as well if anything is found. We also, based on their result and symptoms, may want to do some sort of radiological investigation as well in parallel, and all these things can be done quite well at Macquarie University Hospital.
Once a patient undergoes a colonoscopy, what are the typical next steps?
So it really, again, is case by case, and if you look at the immunochemical FOBT tests, about 5 to 10% are going to end up leading to a cancer being found, but actually about 20% do lead to polyps being found as well. Small polyps, large polyps, depending on the skill level of the gastroenterologist, can be very easily removed. We're trying to move towards more endoscopic treatment of lesions in the gastroenterology world. So we do have colleagues that are therapeutic gastroenterologists, and they can remove giant 3 or 4 centimeter, even larger polyps by something called EST or EMR, which is quite helpful. But I For example, often work on a Wednesday afternoon at Macquarie, and next to me is a very good colorectal surgeon who can simply leave his room, come into my room, see the lesion, and we can make a plan together. And often clients can have their surgical review and multidisciplinary team pathway meetings very quickly to try to help them. Fortunately, majority of the time, we're not seeing cancers, right? But when we do find them, there are really well streamlined processes in place. And the teams that we've got involved, one of the important things to remember is that there are quality indicators of colonoscopies, and we are making these quality indicators mandatory. Viraj touched base on this, things like bowel prep, withdrawal rates, and of course, multiple other facets that are out of scope for today are involved. And we have various systems in this regard to make sure, and reporting on a regular basis to make sure we continue to meet these demands.
I fully agree with what you said. So we are moving more and more towards endoscopic mucosal resection and ESDs to manage these larger polyps. About 10-15 years ago would have ended up in a surgical resection. And sometimes we even find a very superficial cancer in these polyps, and that can be now closely monitored. And after discussing in an MGT, we may not require surgery. So there's a lot of advances in endoscopic therapies for these polyps and lesions. And I think, like you said, Macquarie has one of the largest gastroenterology fraternities, and we've got gastroenterologists from various aspects, from a general gastroenterology to interventional gastroenterology. So therefore, I think we have the ability to manage these patients in a very comprehensive and a multidisciplinary way at Macquarie University Hospital, which is great.
And Brandon, screening rates are increasing, systems are in place, and direct access could be better used. Can you explain what are the risk factors and causes behind the development of bowel cancer?
Bowel cancer and IBD, these things that we deal with, unfortunately, are multi-system and multifactorial reasons behind them. How nice would it be if it was just one thing and we could cure both these issues? But typically, lifestyle and environmental influences play a significant role. For example, diets high in red meat and processed meat. And Viraj and I are both very passionate about diet, especially for our IBD patients. So low intake of fiber, having low fruits and vegetables, obesity, sedentary lifestyle, tobacco use, and heavy alcohol use all contribute to the risk. Additionally, chronic conditions like inflammatory bowel disease and a family history of colorectal cancer increase our client's susceptibility. Essentially, most bowel cancers develop gradually from benign polyps over many years, which is why regular screening is so crucial.
Viraj, building on Brandon's points about IBD and the link to colorectal cancer, why is early diagnosis so important for patients?
I mean, definitely very important, Sally, because untreated inflammatory bowel disease is a significant risk for developing cancer. So it's either bowel cancer or even small bowel cancer. There has been a lot of data over the years that have shown that just ulcerative colitis patients will have about 3.7% of the ulcerative colitis patient would develop colorectal cancer over time, which is about 2 to 5-fold increase in the cancer risk compared to a general population. And certain conditions associated with inflammatory bowel disease, like primary sclerosing cholangitis, increase this further. And it can be a 4 to 10-fold increased risk. So just imagine what we mean by 10-fold is 10 times, not 10% increase. So these cancers can be prevented, because if you control inflammation and if you diagnose colitis or inflammation early, you can reduce their risk over their life period. So diagnosing inflammatory bowel disease early on and having regular surveillance for these cancers is important to prevent these patients from progressing and having a cancer in their lifetime.
And GPs are probably well versed with IBD, but Viraj, for some of our listeners, can you explain what is IBD?
In essence, IBD is a chronic. That's one important aspect of it. So it's been there for a while. It's an immune-mediated condition, so that it's an autoimmune condition where your body is attacking your gastrointestinal tract. And they are classified into two extremities. One is Crohn's disease, one is ulcerative colitis. So a lot of people get confused with what we call irritable bowel syndrome. This is a functional gut disorder. There's no inflammation in the gut. So the characteristic differences are there's inflammation that can lead to these complications such as strictures, fistulas, malabsorption. They do have what we call extraintestinal manifestations affecting their joints, skin, liver, eyes. And then this inflammation can lead to complications in the longer run. And they can be bowel cancer. And Australia is have got one of the largest incidence or the prevalence of IBD. A recent publication by Crohn's and Colitis Australia identified that currently in Australia, we have about 180,000 people living with IBD. 10 years ago, we predicted that we would have 100,000 cases by 2030. And we've gone way beyond that, even before we reach 2030. So there's a huge increase in the IBD prevalence, which is peaking in one of the most important age brackets in a human life between 15 to 30 years. So it impacts your health, education, employment, family planning, quality of life, and significant long-term consequences in mental health. So early diagnosis is so important so that we can address this.
That statistic was so alarming for me, and it will be obviously for you, Viraj, because you deal with really complex and usually unwell IBD patients. And for that rate to go up when we are already overworked is quite scary, isn't it?
Brandon, as Viraj mentioned, IBD is a complex condition with rising incidence in Australia. Can you explain the potential causes of IBD and why early detection and management are so critical in preventing long-term complications?
Look, like most of our inflammatory conditions that we deal with in general medicine, the exact cause is multifactorial and it still remains fairly unclear. IBD is believed to be a result of inappropriate immune response to gut microbiota in genetically predisposed individuals. Genetics has been a little bit disappointing for most of us IBD specialists, and I don't think the emphasis should be on genetics, but there are more than 250 genes involved. It probably provides a predisposition. Environmental factors, though, like diet, antibiotic exposure, urbanization, maybe early life hygiene as well, play probably a larger role in affecting the microbiome and that whole tropical rainforests, as I like to imagine, inside the GI tract that then lead to cascades of inflammation. There's also an increased incidence among migrant populations, and this is why that change in that tropical rainforest is important, and early detection, proactive management, and improved access to special care is the only way we're going to prevent complications and long-term disability. Poorly managed IBD further exacerbates this burden and contributes to significant economic impact, and according to recent analyses, can amount to billions of dollars in healthcare and productivity loss. I remember when I was locuming in a rural region and had met a patient who not only had IBD improperly managed because there was no resources, but also had been on steroids for like 20 years. And we don't even consider the side effects of some of these medications as well as we should in adding to the significant economic impact because they miss work, they become socially isolated, or they get other health conditions that end up causing even more symptoms and health reviews. The hard part about IBD is it's often a hidden disease with subtle or non-specific symptoms. And people have to be really vigilant from all clinicians to ensure that we get a timely diagnosis and effective management.
And Viraj, how do you diagnose IBD in your practice?
Sally, I mean, for us, diagnosis is quite, I would say, simple. But I think where the rate limiting factor is picking up the people high risk of IBD in the community. And I think that is so important to talk to our primary care physicians about. Like Brandon previously said, it's a hidden disease. If you don't think of it in your clinical practice, day in, day out, when a patient comes in front of you with some non-specific symptoms, you will never diagnose it. There will be symptom clues or based on what the patient tells you. They may be talking to you about diarrhea that's happening unusually, waking up with diarrhea at night, abdominal pain that they cannot explain. And you might see some things in your blood test results. They might be anemic, they might be iron deficient, which is inappropriate to their age, or they might be B12 deficient. You might have inflammatory markers raised. And it's a good idea to start a little bit of screening at that time, doing a calprotectin, which is now available for these screening purposes twice a year through Medicare-funded testing, which is great because that will help you to identify the high-risk people that need specialist care, like what Brandon said. Sometimes you may do imaging for abdominal pain, and you might find some changes in the scans that you do that highlights, this patient needs further assessment. I just want to talk about a patient that I recently diagnosed. She was 31 and has been undergoing these vague abdominal symptoms, joint pains, for nearly 9 years. And her biggest problem was joint pains and lethargy. Abdominal symptoms were very mild. And she has been to multiple health professionals, including rheumatologist and other specialist immunologist, until she was seen by a very attentive general practitioner who thought about IBD and did a calprotectin and found the calprotectin to be over 3,000. And then she was referred to me. She had a colonoscopy and she had a diagnosis of severe colonic Crohn's disease. And to my surprise, when I told the patient that she's got a diagnosis of Crohn's disease, because usually we have people crying because they're so disheartened with the diagnosis. But this lady was smiling, teary with smiles, and gave me a hug saying, "Thank God, now I know the answer, why I've been suffering." And this highlights how hidden this disease is. And as clinicians across all the fields, we really need to be thinking of IBD when you have a patient in front. Because if you don't think, you will not diagnose it. When the patient comes to us, we do multiple things. We do a colonoscopy. We may do an endoscopy if we are suspecting upper GI Crohn's disease. We will end up doing calprotectin, blood test, immunosuppressive screens in preparation for a therapy. And currently, we are also utilizing other non-invasive tests like intestinal ultrasound, which is revolutionizing the way that we manage IBD and monitoring IBD. And I think I am at my stage in career is also going to go through the training and learning it. And fortunately, we have experts like Brandon, who has done it from the start here at Macquarie, who's a lead in IUS in Australia. Brandon, do you want to add a little bit about IUS?
Sure. We're not making any magical new things. The skill's been around for 25 years and the equipment's been around. We're just catching up in Australia, unfortunately. A handful of my colleagues and I around in the about a decade ago had to go overseas, often unpaid. I didn't get paid for a whole year while I was in Canada, but I got to enjoy the skiing to learn this skill and then bring it back. And now we've done a really good job with various organizations, including the Genius Group in Australia, to spread the skill and make it really easy. The transabdominal intestinal ultrasound requires no fasting, there's no contrast, there's no claustrophobia, and obviously there's no radiation, which makes it a great tool for repetitive assessments. It's also really important because for us in the IBD world, when we do an intestinal ultrasound, we get satisfaction with an instant answer. So instead of the client coming to you wondering if there's something going on, or if you've started a new medication, they've got a new symptom, wondering what's going on, you don't have to have that lag period of sending them for an MRI or sending them for a colonoscopy, then coming back with results to make a decision. You make a decision right there. It saves the client a couple of days of work and repetitive testing, and it actually helps in the public sector with our clinics that are already overworked as well. It is just another tool though, so it does, sometimes we still need to do colonoscopy, still need to do MRIs for assessments. The good thing about most of our locations now, especially Macquarie, where we have leading experts in MRI, we've got lots of teamwork.
What is new in the treatment of IBD, Viraj?
I mean, I have to be honest, we living in a golden age when it comes to IBD management, and I have seen such a change in IBD management over the last 13 years. It has dramatically evolved where we are not just managing symptoms anymore, and we are aiming for harder endpoints, which actually have long-term impact on patients' life, like endoscopic healing and even mucosal normalization. And there's been a couple of new therapies that has become available in IBD over the last few years, especially making patients' quality of life improve because they don't only need to go into hospitals to get infusions or injections. They can have oral treatments, which are advanced now. One of those additions have been what we call JAK inhibitors, like tofacitinib and upadacitinib. These oral medications that work by blocking JAK and the STAT pathway leads to rapid reduction in inflammation. Some of these drugs have shown benefits within a day and useful in ulcerative colitis and Crohn's disease both. And then there's also what we call S1P modulators, which has been currently approved for ulcerative colitis in Australia. And the newest drug for that has been etrasimod, which prevents cells from leaving the lymph nodes, thereby reducing the migration into the gut and causing inflammation. And these are all great opportunities for patients because patients can have access to these drugs now through our PBS system. And we also have the older players like Stelara, which is the IL-12/23 inhibitor, anti-integrin therapies like vedolizumab, and older conventional anti-TNFs as well. And then on top of that, we still use our thiopurines 5-ASA, but we are trying our best to reduce the use of steroids because we know the long-term use of steroids are a big problem in the management of IBD. Every patient's disease is quite unique. So even though we have multiple options available, we really need to individualize and figure out what best therapy these patients require. And these patients require multidisciplinary approach. It cannot be emphasized that you have to be savvy in IBD management. You need to have your team, which includes dietitians, MRI specialists, surgeons, psychologists, and also our primary care physicians within the shared care model, where we use the medications that are most appropriate to get them into remission, reduce their long-term complications, and also reduce the long-term steroid use. So I think it is very, very exciting. And the biggest thing is that IBD is still an art in management. It's not much in the way of algorithm like in cardiology where someone comes with chest pain, you know what to do. IBD is very unique in that because it's every patient you see every day is completely different. So you really need to personalize your care to that patient. I mean, Brandon, you would agree on that?
Oh, absolutely. I think we've really changed from what are we going to do for the sick patient to it's become an art of choosing in what hierarchy and which order do we use all the available medications to decrease harm, to improve their inflammatory condition, but also, like you said, aim as a person. They're a human being and they're a person with IBD, not an IBD patient. We need to focus on multiple facets of their life so that they can have good quality of life. And that involves getting lots more people involved, including, like you said, our allied health members, but sometimes even talking to other gastroenterologists. You and I bounce ideas off each other all the time. And similarly, a lot of the other gastroenterologists do the same.
Brandon, as Viraj highlighted, there have been significant advancements in the treatment of IBD, especially with the introduction of new medications. Can you share your insights on how you approach treatment decisions for IBD patients and the importance of personalized care in managing this complex condition?
So we just touched on this briefly, but I think the important thing is in all of medicine, including in GP land, I'm sure, we're really trying to respect the wishes of our clients, educating them to empower them to take control of their illness, but also to allow them to try things. It's really interesting that I took over for a very well-established gastroenterologist, and when his older patients come in, there's no question about what. Often, essentially, they come in and they say, whatever you say, doctor, I will trust what you're doing. Whereas the next generation is a little more critical and they may get a second opinion. And then the newer generation actually sometimes walks in after Googling everything with what they prefer to have done before we even have done an assessment. And we have to be able to again, work with our clients. It is their body in the end, and work in parallel to our standard therapies. For example, there are very good natural therapists in the area that respect standardized therapy. And if people want to do methods from them to improve their inflammatory condition, I'm always for it. But as long as I'm aware of what's going on and things are done in parallel, sometimes people even want to try various dietary things. And again, as long as we set time limits on what we're going to be doing, then these things can all be explored. The problem with inflammatory bowel disease is the longer it takes, and Viraj mentioned this, and it's very important, the longer it takes before therapy is initiated and we get some normalization of the inflammation, the more the body's setting adaptations and causing scarring that may require either surgery or cause complications like cancer in the long term. So time is fibrosis, and we need to identify these patients, work with them to give them their individualized therapy, but also prevent harm by acting quick.
Sally, just want to add something to that, Brandon. So I think it's so important. We've as clinicians to identify importance of communication and getting the patient on track, because a lot of the time IBD is affecting young people who have their life and who forget about the disease when they get better. So education, communication, and how you interact with patients are so much important. And then because it's such a complex disease management, we do utilize multidisciplinary meetings to do that. So I think I have to say we are very proud to be part of Macquarie University Hospital, which is also part of, together with IBD Sydney, runs multidisciplinary statewide meetings every year, which is partly sponsored by MUH, to support clinicians to get these decisions. And we use these platforms to discuss about our patients, arrive at the right decision. So utilizing these is an important aspect. And then I think the general practitioners should be aware when it comes to IBD. Management has evolved, and there are subspecialized people who do manage IBD. And it's very important to reach out to these clinicians if you do have a complex IBD patients. And we are very, very helpful, very supportive, and always there to give advice. And it's important to ask for advice when you have a complex IBD patient, because they're not easy to manage.
And how can GPs help improve IBD diagnosis and care?
Sally, I think you cannot say anything more than that. GPs are so important in any chronic disease management and also IBD management, because they're the main link for the patient. They're their friend, they're their local practitioner who they can go and ask any questions. So they're the center in chronic diseases like IBD. So when it comes to the diagnosis, GPs are the first to identify patients who may be at risk. So whether they're through screening, picking up early for signs, and that's how they can help to identify those patients at risk and bringing them to us so that we can make a diagnosis of IBD. And after we diagnosed IBD, like Brandon said, they're patients with IBD, and there are a lot of things that needs to be done. And we always do those with the shared care model with our GPs. GPs are the ones who are going to be, first of all and foremost, find out whether the patient is in remission or whether they have a flare, to inform us. And they're the ones who would help us to manage or monitor patients with regard to drug side effects, because medication we use in IBD sometimes can have serious and possible side effects that we need to monitor them for. And they will be helping us to get the patients vaccinated, because as recently as last year, shingles vaccination has come up to the vaccination schedule, and we are proactively asking our patients to get vaccinated, and we send them back to the GP. And they would also be helping us to do the cancer screening, like looking for patients' skin cancer risk, and monitoring patients for cervical cancer, getting them the HPV vaccination. So, and the other aspect is that IBD is closely linked with mental health. So again, the GPs hold the cards to manage these by creating mental health care plans and sending patients to a psychologist if they need support, and providing them dietary support through a dietitian. So ultimately, I think this is not a disease that is managed by a gastroenterologist. This is not a disease managed by a specialist. It's a disease that requires our general practitioners, us, our surgeons, our dietitians, our psychologists working together to ensure that our IBD patients are managed better.
Sally, our GPs can hopefully not be afraid to directly refer as well. So the direct endoscopy access at any location is going to be helpful for them, and they should try to use that more often. The other thing is, as IBD ultrasound becomes more available, our GP friends can also refer anyone they're worried about having IBD or had an IBD calprotectin test done that might be mildly elevated directly for an ultrasound, and that can often lead into the correct pathway for reviews.
Viraj, what do you do to support GPs?
Supporting GPs, we do many things, Sally. One is education. So we run regular educational events, which I'm very proud of. We do quite a lot through a charitable organization that I'm part of called IBD Sydney. We do run an annual IBD school where we encourage GPs now to come and participate in them, because they can learn about IBD and how to manage and everything. And we also run regular GP meetings. Apart from that, I think the biggest thing that we provide our GPs is being accessible. And I'm easily accessible through the hospitals, and I always give my mobile number and my contact details to my GP colleagues so they can get in touch with me directly. And I'm sure Brandon does the same thing, because it's so easy to sort out any of these issues or help their sick patients quickly if we get that contact directly. And I think gone are the days that we want it to be a referral sent to a fax number or a practice and wait for the patients to come to us. And we would prefer our GP colleagues directly reaching out to us so we can sort things out.
Sally, that case that Viraj demonstrated really well, and that case that I discussed where I locumed in a rural area and someone was on steroids for 20 years, it's just going to get worse if we don't get more help from our GPs and do exactly what Viraj said. There's only about 1,000 gastroenterologists in all of Australia, and gastroenterology is interesting in that it has subspecialties within subspecialties. You have motility experts or liver specialists, or you have IBD specialists or procedural specialists. And so out of that 1,000 gastroenterologists, not all are super IBD efficient. And there's no way we can handle this ratio of increasing diagnoses that Viraj mentioned without the help of our GPs. So we're already handling all these other GI conditions, and even new conditions are coming up like medication-induced ICI colitis. So it's really important that our GP friends are essentially helping with referring and managing more often. And I know they're already doing a very hard job and they're already doing a little bit of everything. But with the increasing rates, we have to put some extra effort into this.
So, Viraj, can you tell us how important clinical trials are in the treatment of IBD and how future treatments will be created?
It's very important, Sally. Like I told you, IBD is a disease in its infancy. We know a lot, but that lot is a very small proportion of what we need to understand how to treat IBD in the future. So clinical trials research plays a huge role. And as a clinician researcher, both me and Brandon participate in clinical trials and research quite a lot, and we publish quite a lot. And I'm so lucky to be at Macquarie, which is a super hub for clinical trials and research, and we run about 10 clinical trials at the moment. These trials give access to patients to newer therapies that might be about 10 years away. And this is a good way where complex patients can also have access to better treatment. And we have a great team at Macquarie, and we run quite a lot of clinical trials at Macquarie.
Thank you to my special guests, Dr. Brandon Baraty and Associate Professor Viraj Kariyawasam. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare education and research. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thanks so much for listening.